Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Summary of Standard Medical Textbooks, that is Standard Medical Notes. So today we will discuss about the topic of peripheral artery disease. Okay, so this is the next topic in the cardinal manifestation of vascular diseases. Let's begin with the name of Almighty. Definition and epidemiology. So, peripheral artery disease is a clinical disorder characterized by stenosis or occlusion in the aorta or arteries of the limbs, leading to inadequate oxygen supply due to chronically impaired blood flow. So, it is nothing but angina of the peripheral organs due to stenosis or atherosclerosis or some non-atherosclerotic causes. So, if this is a plaque, one more is like this is the artery, and this is the peripheral organ. Okay, so this is the plaque. So there will be demand supply mismatch. Okay, because of that there will be ischemia, reduced blood flow to the periphery. So that is nothing but peripheral artery disease. It can be chronic or acute. We'll discuss it later on, chronic and acute. Okay, so what is the prevalence? So the prevalence is increased very much in 70 equal to or more than 70 years of age, that is approximately 15%, and prevalence increases with age. Okay, and one important thing to remember is peripheral artery disease is not merely a disease. It is not merely a disease, but it is an important marker of atherosclerosis of whole vascular system. So you should remember this point. You should not look at the limb only which is affected. So it is an important marker of what is going on in the whole vascular system. So that we should remember, and we should not treat only the peripheral artery disease, meaning only the limb which is affected, but we should think of the whole vascular system, and we should take the steps based on that. So what are the risk factors? So in which patients we see the development of this peripheral artery disease? So important risk factors include smoking is the strongest risk factor, then diabetes mellitus, hypertension and dyslipidemia, hyperhomocystinemia, and renal insufficiency like CKD. CKD is also an important uh, risk factor for peripheral artery disease. So these are the same risk factors which are implicated in coronary artery disease also. So same applies for peripheral artery disease. Smoking is the most significant risk factor, strongly impacts disease progression and treatment failure. So patient should quit smoking. So it is an important factor for treatment failure. So quitting is must. Diabetes mellitus increases the risk of severe limb ischemia. And one important thing to remember in this is the patient who have peripheral artery disease, uh, the patient of diabetes mellitus who have PAD, that PAD affects only the distal or the calcified vessels. So that's why distal vessels. Okay, that's why ankle brachial index is unreliable for the measurement of for knowing the severity and for the diagnosis of peripheral artery disease in diabetes mellitus patient, because it affects the distal vessels, and there are a lot of stenosis in the distal vessels and calcification in the distal vessels. That's why we will not be able to diagnose or mark the severity depending upon ankle brachial index. So in this case, mainly in diabetes mellitus or CKD patients, what we use is toe toe index, something called as toe index, toe brachial index, toe brachial index instead we use. Okay, then hypertension and dyslipidemia, they are stand atherosclerotic risk factors. Hyperhomocystinemia again contributes to the risk. CKD will increase the risk of associated with higher PAD risk and severity. Okay, so these are the stand risk factors. So you should control these risk factors. So not only to save the affected limb, in order to save other vital organs, because other vital organs like brain, heart, kidney, okay, everything will be eyes. They are on risk when you have this PAD. Okay. So what is the pathophysiology? What are the causes of this peripheral artery disease? So we can divide it into atherosclerotic causes and non-atherosclerotic causes. So most common cause is atherosclerosis. So leading cause, more than 90% of cases. More than 90% of cases, this is the leading cause. Lesions typically occur at branching points, arterial branch points, due to turbulent blood flow, and shear stress. So that leads to the formation of atherosclerotic plaque because of turbulent blood flow at these branching points. So what can be the sites, what are the common sites where these uh, atherosclerosis occurs? Okay, so most common is the femoropopliteal. So just I will draw, if this is the thoracic aorta, okay, which gets divided into iliac arteries, right and left, superficial and deep iliac arteries. Then they will continue as the femoral artery. So femoral will be superficial and deep. Then that superficial, that femoral artery will continue as popliteal artery. This will be the knee. This will be the femur. Okay, this will be the thigh. This is knee. Okay, and this will be the lower limb, and this is the foot. Okay, and this popliteal artery will divide into superficial and deep peroneal artery. Superficial and deep peroneal artery, which again divide into posterior tibial artery and anterior tibial artery. So these are the branches. Okay, so now femoropopliteal is nothing but at this site. Okay, at this site. So this is the most common site of uh, peripheral artery disease. Okay, 80 to 90% of patients. So because the occlusion is at this site, at the branching point of femoral artery, popliteal artery, femoropopliteal branching point, so it affects the calf. So this is the calf. Okay, cramping pain in the calf. Aortoiliac disease, so it will be here. So because this is thigh, and here will be the buttock. This is the buttock. So they will experience pain in the buttock, crampy pain in the buttock. And the last one is the tibioperoneal in 42. This is 30% aortoiliac. Okay, most common is femoropopliteal, and tibioperoneal is next common, that is 40 to 50%, and this is more commonly seen in diabetes and elderly patients, diabetes patients. So tibioperoneal is nothing but here. The peroneal artery will divide into posterior and anterior tibial artery, which will supply to the foot. So the distal part is affected. Distal arteries are affected. So they will experience pain in the foot. They will experience pain in the foot. Okay, who have tibioperoneal atherosclerotic peripheral artery disease. So that's the concept. Okay, most common is femoropopliteal. Next common is tibioperoneal, and then the third common is the aortoiliac. Non-atherosclerotic causes are, is number one is embolism. So embolism is nothing but a clot which is formed at one site, say in the heart. A clot is formed due to some atrial fibrillation. Here the clot is formed, and that clot will pass on through the aorta and get lodged somewhere in the downside. Downside it will get lodged. So that's how it causes acute limb ischemia. Okay, so this is the second common cause. So embolism, cardiac origin, atrial fibrillation or myocardial infarction, or some proximal arterial source like aneurysm. For example, a patient who is having thoracic abdominal aneurysm, or uh, aneurysm of the arch of the aorta. So there is a great probability there also for the formation of clot. From there it will go and lodge to the distal side. So cardiac origin or some from aneurysm side. Second thing is thrombosis. So at in situ at the same site, because of some endothelial injury due to smoking. So as smoking causes endothelial injury. Endothelial injury is nothing but the endothelial cells which line the arteries. So because of this endothelial injury, there will be exposure of one Wilbrin factor, VWF. So exposure of this one Wilbrin factor will call the platelets, and platelets will uh, accumulate here at this site, like, and they form a thrombus here. they form a thrombus here. So this is in situ thrombosis or some hypercoagulable state. This is in situ thrombosis or some hypercoagulable states, like for example, patients who have patients who have high hemoglobin, for example more than 17 milligram percentage hemoglobin they are having, or patients who are having that is nothing but polycythemia actually. Okay, so patients for example who are having a chronic hypoxic disease, maybe due to cardiac or pulmonary cause, so those patients will have high hemoglobin. So high hemoglobin means hypercoagulable state. Okay, or some patients like genetic mutations like factor 5 leiden, factor 5 leiden, or some patients who have altered Willebrand disease that you called. Okay, most common causes of this hypercoagulable state is polycythemia. Okay, so these hypercoagulable states or some altered platelets, anything which causes hypercoagulable, dehydration also causes hypercoagulable state. So hypercoagulable states cause thrombosis. Okay, vasculitis, so there is inflammation in the arteries. So when there is inflammation, there is formation of thrombus. Examples for those is thromboangiitis obliterans. As the name suggests, there is thrombosis because of inflammation of the arteries that causes occlusion. This is occlusion, this is inflammation of the artery, this is a thrombus. So that is also known as Buerger's disease, or some other large vessel or large size or medium size arthritis like Takayasu arthritis or giant cell arthritis and Takayasu arthritis. Okay, so vasculitis. Next thing is anatomical traumatic because of some trauma. Okay, for example in popliteal entrapment, so popliteal artery gets trapped. So when there is trapping, again there will be turbulence there. There is a high chance of formation of thrombus there. Okay, and fibromuscular dysplasia, this is a condition which is seen in young patients. Okay, so similar to atherosclerosis, but the content of this fibromuscular dysplasia is different from the atherosclerotic plaque, but it is found in young patients. Okay, so these are the non-atherosclerotic causes of peripheral artery disease. So embolic from the cardiac or aneurysm, thrombosis due to hypercoagulable states, vasculitis, maybe Buerger's disease, Takayasu arthritis, giant cell arthritis, or traumatic. So these are the atherosclerotic and non-atherosclerotic causes of peripheral artery disease, and the most common sites at which the peripheral artery disease can occur we have discussed now. So now, what are the clinical presentation? What is the clinical presentation in these patients? So I will take this upside, or I will take this here. Okay. So clinical presentation. So you can divide into acute presentation and chronic presentation. So first we'll discuss chronic, sorry, and second we'll discuss acute because chronic is more common. I will take this down. So chronic lower limb ischemia. Remember, this is not only common in lower limb, but this is also common in not that much common in upper limb, but I have seen patients and I have treated patients who have come with peripheral artery disease of the upper limb also to me. So causes of upper limb peripheral artery disease include most common causes extra cervical rib. Cervical rib is the most common cause. Okay, so there will be kinking of the artery there. Because of that kinking, there is a turbulence and formation of thrombus, and there will be pain in the upper limb. Cervical rib is the most common cause, and there are other causes, so tumors. Okay, or compression of the artery in between the two ribs. So all those are clubbed into one thing that is known as thoracic outlet syndrome. That is known as thoracic outlet syndrome. TOO, thoracic outlet syndrome. Okay, so thoracic outlet syndrome is the cause of peripheral artery disease in the upper limb. Okay, so first we will discuss about chronic chronic lower limb ischemia. Patients present on a spectrum from asymptomatic to critical ischemia. So it will be a spectrum, like it will be from this is asymptomatic patient. So it is there here only, I will say. Okay, see here, from asymptomatic to intermittent claudication, from intermittent claudication to critical limb ischemia or chronic limb threatening ischemia. Asymptomatic patient, they have significant arterial disease but without symptoms. Why they don't experience symptoms? They have disease but they don't experience symptoms because of sedentary lifestyle. They don't walk very much, they don't do exercise. Okay, or because of some neuropathy. So neuropathy is there, so the sensations, they can't appreciate the sensations. Because of that, there will be masking of symptoms. For example, in patients with diabetes mellitus or chronic kidney disease, there will be associated neuropathy. So because of neuropathy, patient will not appreciate the pain sense only. So because of that, they present with asymptomatic. Okay. Now the next thing is they can present as intermittent claudication, which is the most common thing, common symptom which these patients present. So what is that? There'll be muscle pain, cramping type of pain. Okay. Or there is muscle fatigue. How? Precipitated by exercise, and it will be relieved by rest within minutes. So this is the classical definition of intermittent claudication: muscle pain, cramping type or fatigue which is precipitated by exercise and relieved by rest within minutes. So that is known as intermittent claudication. So depending upon the sites involved, as we have seen in the causes, so the pain, the site of the pain will vary. So it buttock and hip will be involved when there is iliac disease at one side. But remember, there is something called as Rais syndrome. Rais syndrome is, for example, this is a descending aorta, and it divides into the iliac arteries. But a clot is there which is blocking these both branching points. This is the first branching point, but this clot is blocking both branching points incompletely. Yes, of course, it is incompletely blocking both branching points. So that is known as Rais syndrome, because there is blockage in both sides, both branching side. So there will be symptoms. The claudication will be felt in both buttocks. There is a triad. What is the triad? There will be claudication in the buttocks, bilateral, and will be absent femoral pulses. If you palpate the femoral pulse at the groin region, so femoral pulses will be absent, and there will be erectile dysfunction, because there is no blood flow to the penis only. So that's why in Rais syndrome, so Rais syndrome is rare, but bilateral blockage at the branching points of aorta is nothing but Rais syndrome. It presents as a triad of claudication in bilateral buttock claudication, and erectile dysfunction, and absence of femoral pulses. Okay, that you should remember. The next site is the calf. So calf is involved. So when the superficial femoral artery is involved at its branching point, so this is the most common type of intermittent claudication which is seen in the OPDs. Okay, so calf claudication is the most common type of claudication. Then foot, involvement of foot. So this is seen in tibial artery disease, commonly seen in diabetes mellitus patients with diabetes, which is rare. Okay, so most common is calf and buttock, rarely foot. Okay, that is in intermittent claudication. Now this is according to severity of the disease. Now something happens when it reaches to the severe level, then it is known as critical limb ischemia. So it may reach the severe level, either the plaque is expanded, either because of the progression of the plaque, or either there is rupture of the plaque. There is rupture of the plaque, and because of rupture, there is exposure of the substances in the plaque and formation of thrombus here. So these two are the reasons for critical limb ischemia. Okay. So what will happen? How do you define critical limb ischemia? Chronic ischemia more than 2 weeks with rest pain, ulcer, or gangrene. Either of one of these should be present. So more than 2 weeks pain, with more than 2 weeks with rest pain. Okay, pain is there, rest pain along with rest pain. Okay, chronic ischemic pain along with rest pain or ulcer or gangrene. Okay, so this is nothing but critical limb ischemia. So rest pain is nothing but critical limb ischemia, or rest pain or ulcer or gangrene. So rest pain, burning pain in forefoot or the toes, worse at night. Why? Because you will be lying in the supine position. So gravity actually pulls the blood in the limbs. So that maintains the blood supply while we are walking. Okay, but when we sleep, so that gravitational effect will be lost. So because of that loss of gravitational effect, relatively the limb will experience ischemia. So patient will be because of that pain, patient will awake from the sleep, and he will be sitting hanging his legs over the bed. He will be sitting hanging his legs over the bed. Okay, why he does like that? Because he will get some relief by doing that. Okay, because the gravity will pull the blood. Okay, so burning pain will be there. Rest pain is not burning pain in the either the forefoot or toes, only toes, forefoot or toes, which is worse at night. Meaning it is present at the daytime also, but it is worse at night time. Rest pain is there. Okay, tissue loss. or it can be in the form of tissue loss, for example in the form of non-healing ulcers. So these ulcers will be present at the pressure points, or there will be digangrene, okay, chronic pain more than 2 weeks along with rest pain, or ulcer or gangrene. So that's the definition of critical limb ischemia. Okay, so this more than 2 weeks applies only to rest pain, remember, more than 2 weeks of rest pain. Or if just ulcer is there with chronic ischemia, that's also critical limb ischemia. Or if gangrene with critical limb chronic ischemia is there, that is also critical limb ischemia. No need for having 2 weeks. So this 2 weeks is for rest pain, not for ulcer or gangrene. Okay, ulcer or gangrene directly point toward critical stage of the ischemia. So this is a image of a patient who is having peripheral arterial disease, and he is having critical limb ischemia. Because of that, there is a digangrene of the toes due to chronic ischemia, critical ischemia. Okay, so gangrene or ulcer itself says that it is critical, but if there is no gangrene or ulcer, there is only rest pain, that rest pain should be for more than 2 weeks. Now coming to acute limb ischemia. What is acute limb ischemia? Sudden decrease in the limb perfusion. Sudden decrease in the limb perfusion less than 2 weeks, threatening viability. Threatening viability. So this 2 weeks applies for rest pain, remember. Okay, so since there is sudden decrease in the limb perfusion, so that the person is having a sudden onset of no previous history of claudication, there will be no claudication history present, but suddenly he will present with rest pain less than 2 weeks duration. Okay, or he can have claudication history, but less than 2 weeks he will present with rest pain, which will threaten the viability of the limb. Nothing but he will develop gangrene if not treated. Okay, so what are the symptoms of so what is the cause of that? 80% of them is because of embolism from cardiac due to atrial fibrillation or thrombosis, plaque rupture. I said no. So there was atherosclerotic plaque. So there will be, due to some reason, there will be rupture. After rupture, there will be form of thrombus here. So that will lead to critical limb, acute limb ischemia, similar to MI, myocardial infarction. Okay, similar to MI, same thing, but in the peripheral arteries, not in coronary arteries. So what are the symptoms? You can remember it as 6 P's: pain, pallor, pulselessness, piclothermia, paresthesia, paralysis. So these two are these two have some relation, no? Nerve and muscle. So paresthesia and paralysis. So these two have some relation, because artery, if it is not supplying blood, there will be coldness. So pulselessness with piclothermia, and pain with pallor. So pain, pallor, pulselessness, piclothermia, paresthesia, and paralysis. So this is the most critical thing which is going to happen in patient with acute limb ischemia, paralysis. Okay, so pain often severe and sudden in onset, less than 2 weeks. Pale appearance of the affected limb. Okay, absence of palpable pulses distal to the occlusion. There will be coldness of the limb, known as perishing cold, and tingling and numbness, which are the signs. Tingling and numbness will be there. Okay, so these are the signs of nerve ischemia. Loss of motor function. This is because of sign of threatened limb and muscle necrosis. Okay, so these are the 6 P's of acute limb ischemia. So it doesn't say that all the things may present, but when there is sudden onset, the patient present with sudden pallor, pain, pallor. Okay, anything can be there from this 6 P's. Okay, anything can be there from these 6 P's. Not necessarily everything. Okay, particularly this paresthesia and paralysis, they occur late. Okay, so that's about the symptoms of acute limb ischemia. Now, what are the physical examination findings? What physical examination you will do in these patients? So you will inspect the limb first. So chronic limb ischemia patient will have muscle atrophy, hair loss, thickened nails, shiny skin. Okay, one thing you should remember, a sign known as Buerger's sign. Buerger's sign, which is seen in this peripheral artery disease patient. Buerger's sign. Okay, what will happen when the patient raises his limbs? Okay, then he will have pallor in the limbs distal to the occlusion. So that elevation will be just less than 20 degree only. So if it is less than 20 degree, meaning if elevation of less than 20 degree is producing this pallor, then that is a indicator of severe ischemia. Okay, otherwise it is a sign when patient raises his or her lower limb, there will be pallor, and when he will make his limbs lie down, then there will be sunset rubor. This is a actually a metaphor which is used to describe. So when the sun is setting, the reddish thing which you see in the sky, so that kind of redness you will see in these patients when they will bring their lower limb down. Okay, one thing to remember is less than 20 degree if the patient is having pallor, so that suggests severe ischemia. Ulcers, you can notice arterial ulcers, they are present pressure points, for example toes, heels, and remember neuropathic ulcers are also present at pressure points only, but you should differentiate. And the ulcers will be dry punched out ulcers, whereas venous ulcers are medial malleolar site and they are wet ulcers. They're at medial malleolar site and they are wet ulcers, whereas this arterial ulcers are at pressure points. Neuropathic ulcers will also occur at pressure points, but you will be knowing by having by palpating the dorsalis pedis or the other pulses. Okay, if the pulses are absent, it is because of arteries. If the pulses are present, then it is because of nerve. That's how you differentiate. That is inspection. You see the patient, the skin of the patient, the hairs on the skin, the color of the skin. Okay, and you see any ulcers or any gangrene, you will see. And one more thing is you will do this Buerger's test, Buerger's sign you will see. Second is palpation. Then you will palpate the extremity. What you palpate, you will feel the temperature of the extremity, and most important is you will feel the pulses and you will grade intensity. 0 is absent, 2 plus is normal. So remember one thing, whenever you are examining the patient, you should always compare both limbs. Then only you will get some idea that these pulses are less or not when compared. One exception is if the patient has bilateral disease, then that is an exception. But usually you should compare with the other limb in order to get an idea. Okay, that's how you will examine the patient. Check for femoral pulses, popliteal pulses, dorsalis pedis, posterior tibial pulses. Okay, and temperature you will look for. Auscultation, you will auscultate over the iliac and the femoral arteries. So you will see there what that is called as arterial. This said murmur in say, no, arterial. The turbulence you will feel. Okay, turbulence you will feel. Bruit. Sorry, I forgot this. Arterial bruit you will hear in the stethoscope. Okay, when you auscultate. So there is no percussion here, only inspection, palpation, and auscultation. That's all. So that's about the physical examination of these patients. So see, this is the compare this limb with this limb. So this is whitish when compared to this reddish limb, and see the angle. Angle is very much less here, maybe approximately 20 degree only. So this is a severe limb ischemia. Okay, so this is the Buerger sign, which is positive for foot pallor in an ischemic right leg upon slight elevation. So that indicates severe ischemia. Okay, now you have seen the patient, you have taken the history, and you have examined the patient. So how you will confirm and how will you measure the severity of peripheral artery disease? So ankle-brachial index is the one thing which is used to diagnose and measure the severity of the disease. So the primary screening tool. So what it is a ratio of higher ankle systolic BP to higher arm systolic BP. So ankle as SBP by arm SBP, you will take the ratio. Okay, take the ratio. Okay, so this is how they measure the what do you call, radiologist, they measure the ankle brachial index. Okay, so how this ankle brachial index will help us, let us see. Remember one thing, if usually the normal ankle brachial index is 1 to 1.4, normal is 1 to 1.4. If it is more than 1.4, no, that means the artery is non-compressible and it is calcified. So that cuff of the of your BP measuring instrument, so already the artery is what do you call, compressed. So how you will measure the BP? So the more than 1.4 indicates the arteries are non-compressible or they are calcified. So this is often seen in patients with diabetes or CKD. That's why in these patients who in whom you get the ABI as more than 1.4, you do toe-brachial index instead of ankle-brachial index. Okay, and if toe-brachial index is less than 0.7, that confirms the peripheral artery disease in patients with diabetes mellitus and CKD. Okay, now coming to the severity, how you'll assess the severity by using this ankle-brachial index. So less than 9 is diagnostic of peripheral artery disease. Just remember, less than 0.9 or equal to 0.9 is peripheral artery disease, that is confirmed. And if it is between 1 to 0.9, then it is early, it may be early peripheral artery disease. Okay, because the normal is 1 to 1.4, but if it is between 0.9 to 1, then it may be early peripheral artery disease, we don't know. But if it is less than 0.9, it is confirmed. If it is less than 0.5, that indicates severe peripheral artery disease and critical limb ischemia risk is there in these patients. Okay, severe pulmonary artery disease and there is a risk of critical limb ischemia in these patients. You should plan for management urgent in these patients, either a bypass or catheter thrombolysis, or you take out the clot from the artery. We will discuss that management part. Okay, so further testing, what you will do, so toe-brachial index, when you will use, so in patients like diabetes mellitus and CKD, where you get ABI more than 1.4. So normally it is more than 0.7, but if it is less than 0.7, that confirms the peripheral artery disease. Other things are also there. I will say first important things. Duplex ultrasonography is one important thing. This is a first line imaging. What it tells, it helps us to localize the lesions. So remember one thing, there can be lesion, but there can be no peripheral artery disease. It depends. Like the coronary artery disease. So if there is 50% occlusion of coronary artery, patient may not have angina. Okay, and in these patients, no angioplasty or something like that is required. Just if you give aspirin and statins, the clot will resolve itself. Similarly, you can have lesions, but you will not have. That's why you should not use just the ultrasonography part. You should also see the ABI, ankle-brachial index, to confirm and for the severity, and to localize you should use duplex ultrasonography, and that will also help to monitor bypass graft. Okay, one more thing is CT angiography or magnetic resonance angiography. This is an advanced imaging. Okay, this is done when you are planning for any bypass or something like that. Okay, second thing is catheter angiography. This is done when you are planning for thrombolysis, meaning not systemic thrombolysis. You are passing a catheter into that artery, and through that catheter you want to thrombolyze that patient. So that is known as endovascular intervention. Okay, this is the gold standard invasive investigation, DSA, catheter angiography. So remember, so at many sites CT may not be available. So you can use toe-brachial index, ankle-brachial index and duplex ultrasonography to localization. Later, the surgeon will do the CT angiography or MRA, something, all those things, to plan for the management of the patient, the management which suits better the patient. Okay. See that in that image you have seen the ankle index. Here you see toe-brachial index, something like that. It is measured. Okay, toe-brachial index measurement. Sorry. Okay, that's all about till now. We have learned the investigations, up to investigations well learned. So in the coming video, we'll discuss about the next. It will be end of this chapter in the second video. Thank you.